Good afternoon and welcome to today's webinar, Navigating the IAC QI Tool, Collect, Measure, Improve. My name is Kelly Baer and I am the Creative Design Manager with Marketing Communications at IAC. Before we begin, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like today's webinar to be interactive, so we encourage you to submit questions. To do so, use the Questions tab located on the left side of your screen. Please submit your questions anytime during the webinar, as we will monitor questions throughout the presentation and try to answer as many as possible during the Q&A period. On the left sidebar, please note the Polling tab. Today's webinar will feature 3 live poll questions for our audience. Also on the left sidebar is the Resources tab. Click this tab for links to today's handouts, which include a PDF copy of these PowerPoint slides. Select the file name to download the handout. Lastly, in the lower left of the player, please note the Request Support button. If you experience any technical problems during this webinar, click this button. A technical expert will be there to assist you with any issues you may have. For those who like to take notes during the presentation, look to the right of the slides and click the Notes tab. There you will see a white text box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the session. To be eligible for the Voice Category A CE credit, you must be registered, logged into this webinar, then complete the survey. The survey will appear on your screen automatically at the conclusion of the live session and also be available from the IAC webinar portal for 3 business days. If you are viewing this webinar in a group, please be sure you are also individually registered and logged into this webinar on another computer or device so that we have record of your attendance today. Today's presentation is being recorded and will be posted at a later time for on-demand viewing. This presentation is intended to help facilities gain a better understanding of the IAC process. And with that said, I will now turn this webinar over to today's speaker, Maria Costello, IAC Director of Accreditation for Nuclear PET. Maria?
Thank you, Kelly. And thank you everyone for joining me this afternoon. I also just want to take a minute to thank you all for doing what you do, providing quality patient care during this stressful and challenging time. We at the IAC want you to know that we are here to help. Please don't hesitate to contact us with any accreditation questions or concerns. The objectives for this webinar and what you should be able to do by the end is describe measures of quality improvement, to discuss the goals and benefits of the IAC Quality Improvement Tool, and to explain how to use the Quality Improvement Tool. The IAC Nuclear PET has quality improvement program requirements, and we require certain measures to be completed annually. The 4 measures are Test Appropriateness, or AUC, Technical Quality Review, Interpretive Quality Review, and Final Report Completeness and Timeliness. Test Appropriateness, or Appropriate Use Criteria, there is not published criteria for every imaging procedure, but you can determine the appropriateness of the study just by the clinical indication or the reason for why the study was being ordered. For Technical Quality Review, this is where you're going to look at the quality of images or processing, really the technical aspect of the study, anything about the image acquisition and what the overall image looks like. For Interpretive Quality Review, we're not asking anyone to reinterpret studies for this measure, but we want you to look at and determine whether the interpretation is accurate. This is where inter and intra observer variability comes into play. In other words, with the physicians, if you have physicians review studies that they've already reviewed, if it's the same physician, you can have the same physician review studies that he has interpreted, or you can have different physicians peer review their studies, and that helps to ensure the accuracy of the interpretation. And the last measure is Final Report Completeness and Timeliness. This measure is just really making sure that your reports contain a lot of the required demographic data. All of these requirements that we have are listed and found within the standards as far as what needs to be included in the report. And it's also looking at the timeliness of your reporting. And you need to ensure that your reports are signed and finalized within 2 working days. The QI program requirements also include that you must review and maintain minutes or reports of QI evaluations and document any corrective measures that are taken. We do require you to have 2 meetings a year, and all staff must attend at least one of those meetings. Now, we are not saying that they have to be attended in person. You can do them over Skype or some other sort of web conference. We know it's kind of hard to get everyone together, and especially now with social distancing. So we're not telling you that everybody has to meet face to face, but you are required to have these 2 meetings a year. We do have, and we came up with a very easy way for you to complete this and make the quality improvement make a little bit more sense and make it easier for you to determine the quality of imaging and reporting that's happening at your facility. The IAC QI self-assessment tool helps you to review and evaluate your images and reports. It provides a data-driven, objective measure of the QI progress. It creates a quantitative report that identifies opportunities for process improvement. It also satisfies other quality initiatives such as MOC. And MOC is maintenance of certification. Most physicians need to have so many points for their maintenance of certification. And the QI tool does qualify to provide points for the ABIM, or the American Board of Internal Medicine, and also the ABR, which is the American Board of Radiology. You can also benchmark your findings internally by using the QI tool. We do not require that you use the tool, but using this, as I said, you will meet all of the QI standards at once, and you don't have to do all separate projects. It's going to put everything together and make it make a little bit more sense. You can also use this tool as frequently as you'd like, and that helps to provide continuous improvement at the facility. You can also use this tool to review cases that you are going to submit for accreditation or reaccreditation, because essentially the questions that you will answer within this tool are the same questions that the peer reviewers use when they're reviewing the cases that you've submitted. And you will be able to determine if you are meeting the standards. The whole purpose of the QI self-assessment tool is to educate facilities on how to perform self-assessment and peer review of cases, recognize any deficiencies within the different measures, and implement corrective action or process improvement when these deficiencies are identified. The QI self-assessment tool is incorporated into the online application, and it has 3 main parts. You're going to select the cases, you're going to review the cases, and then it will provide an assessment summary report. So where exactly do you access the tool? You're going to log into your online account. And then across the top, there are all the different tabs where it tells you you can also view your application, but there's a tab that says quality improvement. You're going to click on that, and then it's going to bring you to the QI overview page. For our purposes, you're going to click on Nuclear PET, and you will create a new assessment. An assessment is actually a group of cases that you are going to review. So once you create that new assessment, you're going to enter those cases in. You can enter as many cases as you like, but just keep in mind that the more cases you enter, the longer the report will be. So we don't recommend that you enter any more than 20 cases in, because your report will be way too long. So you can also use this tool as frequently you would like, and you can create as many assessments as you would like. When you're adding the case in, you're going to type in the patient name, the date of the exam, what type of case it is, and now there is an optional feature where you can, if you have more than one site listed in your accreditation, you can select which site that study was performed at. You're also going to enter in who interpreted it. There is a spot for identifying information. This is optional, and there's no sort of designation for what this is. It's really just up to your facility if you want to put any other identifying information in there. Once you get done entering all the cases in that you want to review, you're going to assign staff to review. Each case in an assessment can be assigned to multiple reviewers, which would allow for peer review. You can assign them to as many as you want, but you must assign each case to at least one person. The cases do not have to be assigned to the same people. You can have just physicians reviewing a case. You can have just technologists reviewing a case. You can have a combination of the two. And even if there are 5 cases within the assessment, you can assign all 5 of those cases to a different group of people. You don't have to assign them to the same. The caveat to it is when you go to assign the cases, when you actually click on that assign button, the only staff that you're going to have the option to assign are ones that have verified their email address. So if you have a staff member that you know hasn't verified their email address before you assign the cases, make sure you have them do that. Then they will show up on the list. Once you have assigned all the cases that are in that assessment, you can click on Submit Assignments. If there are any cases that you haven't assigned at least one person to review, you are not going to have the option to submit the assignment. So just go back through your cases and make sure you've at least checked off one person to review the cases. Also keep in mind when you're assigning the cases to reviewers that the images and the reports are not uploaded into the tool. So anyone that's assigned to do the review needs to have access to review these images. They need to have access to the images and the reports in order to review them. So once all of the cases have been assigned and you submit the assignment, now it's time to review your case. Every person that is assigned to review will receive an email notifying them that they've been assigned a review. And at that point, they will log into the system and begin the case review. The first question that they will see is obviously the appropriate use criteria. Once that question is answered, it will move on to the technical quality review. The technical quality review is going to ask questions such as is there artifact present? Has the study been processed correctly? Are the regions of interest drawn accurately and appropriately? Has the study been displayed correctly? Or is a conventional slice display used? Are slices aligned? These questions will be, they will correspond to whichever case type you picked for that case. So if you picked a myocardial perfusion imaging case, the questions are going to be specific to that. Within general nuclear medicine, we have specific questions for each area under general nuclear. So there will be separate ones for a bone scan as opposed to a thyroid scan. So now we're going to answer a little poll, and it's kind of to simulate the QI tool. Obviously, we can't go through every single question, but I'm going to show you an image in a second, and I want you to answer the poll question of, are the slices aligned? Okay, very good. So 91% of you said yes, they were aligned. That is correct. So as you can, what we mean by this is that when you look at it, they're all in the same, they all look the same, whether it's the stress or the rest, they're just lined up appropriately. Okay, so next we'll move on to the interpretive review. And with the interpretive quality review, you would answer questions such as, are the results of the stress and imaging portion integrated? And you'll have a series of questions about what needs to be included in that integration. You would have to include, it's going to ask a question about the defect description. Are any pertinent positive and negative findings described? Does the report include a succinct impression, which means that there's a direct statement of abnormal or normal? So we're going to do another poll question. Obviously, again, we can't go through all the questions, but the poll question is the defect type described? So you'll just read this little part of a report and answer yes or no. Is the defect type described? Perfect. 83% of you said yes. So I'm going to give a little bit of an explanation on this one. It needs to specifically be stated whether or not the defect type is reversible, fixed, or mixed if it's a combination of a reversible defect and fixed. So the first sentence describes the resting SPECT images and what the rest images show. The second sentence describes what the stress images show, but there's no combination of that to say this is a fixed defect. So that's why, yes. So I reversed the answer is no to that question. So the defect type is not described. So there was a little bit of confusion with that one. So as I just said, the rest SPECT images show, it describes what the rest SPECT images show and then what the stress SPECT images show, but it never says that it's a fixed defect. The next section is on report completeness and timeliness. In this section, you would answer questions about the required demographic data. And again, these requirements are found within the nuclear PET standards. It would have the facility identifying information, the patient date of birth, the patient gender, a description of the procedure, and also things like the date of report. We have one more poll question. I'm going to show you, it's a longer paragraph, but does the report include a description of the imaging procedure? Perfect, 68% of you said yes and 32% said no. There is a description of the procedure. If you look at the line, the protocol line, it does say it's a 1-day exercise rest and then stress myotech 99 and MyoView study. And also within the procedure, the second paragraph says at rest, and it describes how much was given, and then at stress, and it goes through that. So there is a description of the procedure. So then once all of the reviews have been completed, that's when the summary report will generate. And that at that point is the only time that you will have the option to view the report. This summary report will show for each case the right and wrong or discrepant answers between reviewers. It'll also show a case quality score as well as a staff agreement score. And then there will be a case quality summary graph at the end. This report is what is going to be used for discussions in your QI meetings. Now, since the report includes each case that you had separately, you're going to have to summarize the findings. When you summarize the findings, you need to ask yourself, what do I do with this data? Okay, so were there discrepant answers between reviewers, or were there any wrong answers? What are you going to do to correct it? And then you're going to discuss those results in your QI meeting and document it in the QI meeting minutes. So if there were discrepant answers between reviewers, then that's going to create an educational point for you to talk about in your meetings, because why isn't everyone agreeing on whether it's the technical quality or the interpretive quality? And it just provides education and conversation and communication. Were there any wrong answers? If there were wrong answers, what that means is that you may not be meeting the standards. So you're going to want to go back and take a look at the standard that's affiliated with the question where it was wrong and just review what those requirements are. So once you identify what the issue is, you need to determine what was needed to fix it. Was there an issue under test appropriateness, technical quality, interpretive quality, final report completeness and timeliness? So for this example, let's just say that it was under technical quality and you found that a lot of the patients, or majority of the patients that you looked at, maybe 10 out of 10, had excessive bowel uptake on the stress images. So again, you want to clearly define what the problem is. What is it that you really want to improve? What is the source of the problem? So you notice that there's this excessive amount of bowel uptake. So you want to improve the quality of the images because it may be causing an artifact on the images. It could be overlying the inferior wall of the heart. It could make it look like there are defects. So you just want to clear that away. What is the source of the problem? Well, it could be that you're not waiting long enough to scan the patient after the stress images, or maybe you want to have them eat something after the stress images to have that bowel move through. So that's the next step. Describe what change is going to take place and the time frame for that change. So you don't want to try and make two changes at once. So you want to decide which one you want to try first, because then that's the way you will know whether or not which angle has helped. So if you think it's because you're not waiting long enough before you scan the patient, then start with that first. And you want to make a plan to say that, okay, we're going to now wait an hour after the stress testing before we scan the patient. And we're going to reassess by looking at 20 patients in 2 months and reviewing the studies. Keep in mind when you reassess that the dates that you are looking at or reviewing studies, it needs to be after you implemented that change. So once you go to implementing that change, you want to test it and make sure that it has worked. So data is what actually measures that change or determines whether or not that change is due to chance or that it actually made a difference. So in that 2 months, you're going to look at another 10 or 15 patients and see, did it stay the same? Did it make a difference? If it didn't make a difference, you're going to reconsider. You're either going to say, well, maybe we need to try this a little bit longer, or you are going to try something new and then maybe say, okay, so let's have the patients go and eat something and then have them come back and let's see what happens. And again, you'll go through this same process again, deciding what you're going to do, and then determining a time frame that you're going to look at it again, because you want to keep testing what you're doing to ensure and not just assuming that you're making a change, a difference. So with all of this, what exactly do you put in your meeting minutes, or how do you document your meeting minutes? For each measure, you want to list out how many patients you looked at and what you found. So let's say you looked at 10 patients, and for test appropriateness, you found 10 out of the 10 patients were appropriate. That's what you need to list. Don't just put in there 100% of the patients were appropriate. You need to see how many patients and what you found. Technical quality review. 8 out of the 10 patients had excessive bowel uptake on the stress images. There was no motion artifact. The count density was good. Just everything that you looked at within the technical quality. For the interpretive quality, same thing. How many patients you looked at and what you found. It's kind of repetitive, but it at least breaks down each measure and shows you where you can make these small improvements. The next part of the meeting minutes would be the corrective actions or the improvement plan that you put into place. So again, this is where you're going to list out, we're going to have patients wait an hour before we scan them for their stress images. And we're going to reassess this in 2 months, 3 months, whatever you choose. You're also going to list any other comments that were made or any other educational pieces that were made during the minutes. So during the meeting. So basically what these minutes are a record of what you talked about. And that way you have something to go back to, you have something to learn from, and you can keep referring back to them and keep them for comparison. The final part, and I'm talking kind of quickly, so we should have a lot of time for questions, but the final part that I'm going to talk about is under quality improvement is the QI analytics that you can get from using the tool. And this will also help you to keep track of benchmarking yourself throughout periods of time. So for this, again, you go under the quality improvement tab, and then you click on the QI analytics section. Under that, you're going to select the type of report that you want. you can look at the QI tool usage. You can look at a report for case quality. You can look at a report for staff agreement. Once you select which report type, then you're also going to decide, obviously this is nuclear, so you're going to pick the nuclear PET modality. Let's say you just want to focus on myocardial perfusion imaging, or the case type would be myocardial perfusion imaging. Then you're going to select which metrics. And the metrics are the test appropriateness, technical quality review, interpretive quality review, and final report completeness and timeliness. Then you can also select where it's been performed. So if you remember back in the beginning when I said when you're entering the cases in, there is a spot to identify which site that study was done at. So this is where it would be important, because when you look at these analytics, you can either look at all the sites or you can look at each site individually. So let's say that you pick nuclear PET with the case type of myocardial perfusion imaging. You're going to you want to see just the technical quality metric performed at all sites, and then you pick a time period, and you can do it by month, you can do it by year, it's up to you. So then you can see a graph will populate and it will just show the technical quality review. You can do it using only two metrics, where you look at the technical quality review and the interpretive quality review. And again, I picked for this one the case quality report. So this will tell you each metric percentage for the case quality. You can do all four at once. Same thing, it will identify the percentage of the case quality for each one of the metrics. So in summary, QI is not meant to be punitive, divisive, or busy work, but it is about looking at what you do and figuring out how you can do it better. Quality can be improved by looking at your work performed, how it's done, and how it can be done better. And the IAC QI tool can do just that for your facility. The more you use it, the easier it becomes, the more you realize what you're looking at. It is the same platform that we use at this time when you get an audit. Every facility that is accredited with us about halfway through gets an audit or a site visit. And during the audit, it is the same platform. So if you've done an audit, you should already be familiar with this platform. And that's all I have for my presentation, which we have lots of time for questions and
Okay, thank you, Maria. At this time, we will begin the Q&A session. From IAC Nuclear PET, I'd like to introduce John Lilly, our clinical specialist. He will assist with the audience questions today. John, would you like to start us off?
Thank you, Kelly. The first question is from Patricia. She asks, other than the interpreting physicians and technologists, who should be attending the QI meetings?
It's mostly important for the interpreting physicians and the technologists to attend the meetings. Those are the most important. However, if you have nurses, let's say you're doing stress testing and you have nurses or physician's assistants or medical assistants in on the stress testing, you may want to include them so that they can help to see how this all gets put together, and they can also help to improve the quality. Sometimes people that aren't necessarily 100% involved can see certain things that we can't see, or they can ask questions that trigger different educational points. So it's really good to include everyone just as education for the entire facility, but most importantly, the interpreting physicians and the technologist.
Okay, next question is from Dave. Are there recommended thresholds for facilities when using the QI tool?
There are no recommended thresholds. It's really up to your facility and what type of thresholds you want to set. The main thing to keep in mind is you don't want to set them too high. With quality improvement, number one, you don't want to see yourself scoring 100% every single time, because maybe you're not looking as in depth as you should be. So don't try and strive for that 100, but you also want to set a threshold that's reasonable. So you don't want to say, we want 90%. We want everything to be 90% accurate. Maybe start out with something lower, and then as you meet that threshold, then keep moving up little by little by little. So you keep raising that bar. I think that answers your question, but please provide a follow-up question or contact us afterwards, and we'll be happy to expand on that more.
The next question is from Joyce. Is there a number of cases that must be assessed per year?
Again, that is up to your facility. I know that we previously had a requirement that for each measure you had to assess at least 30 cases. And in our standards under the appropriate use criteria, it still does give that recommendation. However, it's really up to you. Since you can use this tool as frequently as you would like, meaning that you can use it every month, you can use it every week, it's really up to you how many patients you want to look at. But also, you want to make sure that you're looking at a large enough sample size that's going to be a good representation of the work that's being performed at your facility. So you don't want to just look at 2 or 4 patients a year. That's not enough. You want to make sure it's a good percentage. And as I said, because you can use this so many times, you don't have to look at 20 at once. You know, if you say in a quarter, you wanted to look at 20, well, then you can look at 5 patients a month. It's really up to you.
Okay, the next question is from Ellie. We have an off-site reading physician. Is he to be included in the meetings?
He absolutely should be included in the meetings. Each physician needs to be included in the discussions that you have, because if you're trying to make improvements to the interpretation or to the final report completeness and timeliness, or even having discussions about the technical quality, he may be seeing something from another perspective that he needs to be included in the discussions, or that way he can hear what the other interpreting physicians say, and everyone stays on that same page and makes the same improvements and begins to work together making these improvements.
The next question is from Jay. Is there a specific AUC tool that is recommended?
So I know that, with myocardial perfusion imaging, for a long time, Astellas had the tool that really helped with it. That tool has gone away. They do not offer that anymore. And unfortunately, there are no tools that are similar to that are available. Keep in mind that there is the PAMA law that is being implemented, and what that law is requiring is that the appropriateness of the study must be quantified before the study is actually performed, and eventually reimbursement could be affected because of this. If you have any questions about that, I do direct you to the American Society of Nuclear Cardiology website. They have a lot of really good resources about that law, but we don't have any sort of tool that can help with it.
Next question is from BJ. In a facility with only one interpreting physician, how should peer review be accomplished?
Well, it's not necessarily peer review, but with one physician and, the technologist, you can all review. It's also him over reading the studies that he's already read. And sometimes when physicians do go back and read it again, they may find little details. So while you may not necessarily be able to perform a peer review, there is still that variability that can be found.
All right, the next question is from Melinda. Does the interpretive quality review need to be done by doctors, or can technologists do it as well?
Technologists can do it. As I mentioned earlier, for the interpretive quality review, we're not asking you to perform a new interpretation. We're basically just asking that you look at the interpretation that is there, and does it seem accurate to you. Within the QI tool, there are specific questions that we ask about this, and really, if you should be able to answer them just using the report and the images. So it doesn't necessarily have to be a physician. It's also, you're not I know that some technologists may be afraid or a little apprehensive about doing the interpretive review, but there's really no reason, because again, if you answered something a certain way, and the QI tool isn't going to tell you who's answered in which way, let's get that clear too, but if you've answered a certain way and the physician, says, no, that's not the way it is, it again gives an educational point for them to explain further to you about the interpretation or about the images and why he came to the interpretation that he did.
All right, the next question is from Randall. Can these QI meetings be eligible for CME credits?
No, the QI meetings are not eligible for CME credits. The requirements of the standards, and they're to help improve the quality of your facility, but they are not eligible for CE or CME credits.
The next question is from Ricardo. How long do we need to keep the QI meeting documentation?
That's up to you. We do recommend that you at least keep it for your accreditation cycle. If you do get a site visit, when we come in, we are going to review that documentation to ensure that you are completing the 4 measures annually. So you'll want to at least keep it for the 3-year accreditation cycle. If you choose to keep anything longer than that, then that's fine. It's up to you, but we definitely recommend and advise you to keep it for the 3-year cycle.
The next question is from BJ. Does the IAC QI tool help an imaging facility fulfill the CMS patient assessment appropriate use criteria?
No, it doesn't. We are asking about the test appropriateness, but it doesn't fulfill that requirement.
All right, the next question is from Cheryl. Is injection to imaging time required on final reports?
Injection to imaging time is not required. If you have it on there, that's great. Any additional information that you provide in a report is great, but it is not necessarily required to include the injection to imaging time.
The next question is from Iris. Is it necessary to include height and weight on the MUGA reports?
Yes. Currently at this time, the standards state that height and weight or BMI is required on every final report, meaning myocardial perfusion imaging, any form of nuclear cardiology, any PET imaging, any general nuclear. So height and weight or BMI is required.
The next question is from Alex. Are cath correlations still relevant in the QI program?
They are still relevant, and they are very important. You will see within the QI tool, there is a question under the interpretive review that asks if the study was correlated with another study. This is especially referring to, in MPI images, especially referring to that cath correlation. There's a second question that will ask if the study's correlated. You can answer those questions yes or no, and there is a comments box at the end of the section that you can type in any relevant comments to that entire section. But if for some reason it didn't correlate, that's where you could include that the cath and the images did not correlate. But it is all relevant to the interpretive measure.
The next question is from Rafiq. How do you improve test appropriateness for studies?
That's a challenging one, and I'm not sure that I am the appropriate person to ask that question to. It's something that you need to discuss with your physicians and figure out where most of your inappropriate studies or sometimes appropriate studies are coming from. If they're coming from referring physicians, then there might be education may need to be provided to the referring physicians. That's as far as I'm going to go with that question, because that's a challenge that I think everyone faces, and I'm not sure that there's one set answer for that.
Okay, the next question is from Ginger. With the dose limits, is 10% plus or minus still acceptable?
Yes, it's still acceptable.
All right, the next question is from Jason. Can we get physicians to assess only the interpretive quality in the QI tool?
So at this point, No, they would have to go through all of the questions. It will throw, if they chose to just answer the interpretive part and just kind of click answers for the other measures, you would need to definitely keep track of that because your data would be off, your analytics would be off. So, it's up to you how they do it, but really even the physician should be looking at it totally, because if they see an issue with the technical quality, you're going to want to address that as well. I know that sometimes it's challenging to get physicians to be that engaged, but it really is important to the overall quality of your facility.
Next question is from Gino. Is there a way to break down which interpreting physicians are accurately reporting and which ones are struggling to hit all the aspects needed, or is it just an overall score per site?
So there are ways to do that, but the way this works is it's just giving you the overall score per site. As much as there's no finger pointing in quality improvement, but you do have those physicians that have pain points. You would like to think that when these reviews come up, if you have enough of the studies reviewed from a certain physician, that's going to come up as to why all of this is missing. You will always know what physician interpreted the study. So you can do your own sort of tracking of that, but the QI tool itself is not going to target certain physicians unless you were to just put case studies from that particular physician into one assessment and have it reviewed by other physicians and technologists.
Next question is from Giovanni. For accounts with 10 plus sites, how would you suggest using the QI tool? How many patients per site?
That's really a tough question, and it really just depends on what the volumes are at each one of those sites and how many patients you're looking at from each of those sites. So again, you need to look at your total volume from each site as well as the primary site and decide how many cases from those sites you want to review. If a site is only performing imaging 1 day a week and they're only doing 2 patients at a time, you're not going to say we need to look at 20 patients from that site because they may not even have that many done, in a month. So you just have to decide on what works for your facility and what is giving a good assessment of the volume that you're performing.
Next question is from Elda. Do you recommend that all reading physicians have the ability to review the studies in the QI tool?
I do. I do recommend that for many reasons that we've discussed in a few of these questions. When you have physicians reviewing each other and reviewing themselves, and the more you have, the more educated everyone becomes, and the more physicians start to realize what is required in the report, what is required to make for an accurate interpretation and meet our standards as well. So I do advise that. I know that, as I keep stating, I know that sometimes it is very challenging to get interpreting physicians engaged, but if it is possible, it would be best to have all of the interpreting physicians.
Next question is from Donna. Does the impression need to start with normal, abnormal, or equivocal?
That, we don't say which order it needs to start with. What we do say is that the impression does need to include that direct statement of normal or abnormal. For MPI studies, it doesn't only need to say normal or abnormal, but if it says abnormal, it does need to include whether it's deeming the findings as ischemia or infarction. So what order you choose to put it in is up to you, but it is required in the report.
Next question is from Jill. Are there any plans to extend the audits at all?
I'm not sure what that question is referring to, and I'm not sure if it means the due dates for when the audits would have to be submitted, especially in the times of COVID now, which we are extending the due dates for the audits. So I think with that question, it may be best if you either email me or call me after this webinar and we can discuss.
Next question is from Eric. We are accredited in both cardiac PET and SPECT myocardial perfusion. Would we need to have separate data and QI analysis for each respective modality, or would we combine them?
It's up to you how you want to look at it. You do need to look at both because obviously you want to make sure you want to ensure quality of both. But if you choose to do an assessment that has a combination, that's fine. I know for a lot of these answers, I keep saying it's up to you, but that's what we're trying to reinforce. This is purely for you and to help you improve the quality of imaging at your facility. So however you choose to look at it, we are here for guidance and we will definitely help you. But if you are accredited in both SPECT and cardiac PET, then yes, you do need to look at both, but how you look at that is up to you.
Next question is from Rosemary. Can you please review the appropriateness of use section in the QI tool?
So the appropriateness or appropriate use criteria section of the QI tool is one question, and it basically asks if the study is appropriate, and it gives the 3 levels of appropriate. We at the IAC cannot assess that, so I can't. You need to be able to do that looking at what the clinical indication is for the testing, and also you have the history of the patient as well as the report, and you would be able to better determine that. There's not a whole lot that goes into it. It's just verifying whether the study was appropriate or not.
Okay, the next question is from Anthony. For the QI meeting, can we discuss COVID-19 protection for staff and patients? Is it relevant?
I think it's important for you to discuss it in the QI meetings, but no, it's not. It doesn't fall within any of the measures, but I do feel that it is appropriate for you to discuss within your facility.
Next question is from Joyce. Can you review past QI assessments on the IAC website?
It does save you can archive the assessments and review them. So you can archive the old ones. You can always go back to them, and that is where the analytics come into play. Is from, that's how you get the time frame. It's assessments that were completed previously compared to assessments now, and you can decide what time frame that is. So yes, you can absolutely go back. You can archive them. You can look at the summary report. Everything is still there.
There's another question from Susan. Have CE requirements been extended for a year due to the cancellations in meetings?
Yes, there has been a waiver for CE and CME for 1 year for facilities due to the pandemic and the fact that meetings have been canceled, and it's definitely not easy for physicians and technologists to attain the credits at this time. So there's a 1 year waiver.
Karen has a question. She says, how do we contact someone if we have questions related to IAC recommendations but not included in this presentation?
You can email me directly, and it's you can find my email address on the website. It's mcostello@intersocietal.org. My direct number is 443-973-3241. Feel free to call me, and I can answer any of your questions or discuss with you anything you'd like.
Next question is from Ricardo. Can the meeting minutes be typed online in the online tool, or do we have to print them out and keep them in a physical file?
You do. They can't be stored in the tool. The only thing that's in the tool is the summary report. The summary report is not considered your meeting minutes. The summary report is what you're going to use to generate your talking points for the meeting. The meeting minutes need to be kept on file, however you choose to keep them on file.
Is the percent heart rate above 85% needed to be included in the final report?
Yes. The maximum predicted, the heart rate that the patient achieves for an exercise stress testing is required in the final report.
Next question is from Mr. Seswati. It says, for route of administration, is IV good enough, or do we need to say right antecubital or right hand?
IV is fine. That obviously means intravenous. What is not acceptable is if you just say injected. So if you say 10 millicuries of MyoView has been injected, that's not acceptable. You would need to say injected intravenously, IV, however you want to say it, but it needs to be the specific route of administration. We don't necessarily need to know that it went into the right antecubital, the right hand, wherever. It's good to keep a record of that, but it doesn't need to go in the final report.
Next question is from Michael. It says, due to COVID-19, our volume has dropped 90 to 95%. Is the IAC taking this into consideration with the number of case studies we provide?
There are discussions that we will have with each facility as the time comes. Obviously, as I stated in the beginning, we are here to help. We understand that volumes are down. We do understand that, we're going to have to take a look at the case study requirements and we will assess them in a case-by-case basis. I cannot at this time make a blanket statement about that. So if you do have questions, feel free to contact me and we can have a discussion.
Next question is from Stacy. We are currently running one tech at 2 locations. Can the same tech review the exams they perform? Yes,
they can. That happens quite a bit. And again, it's the same thing like having the same physician review the exams. You're very busy throughout the day, and sometimes when you take a look at things at a different time, you may find ways to improve things. It's absolutely okay for the same tech to look at studies from both.
Okay, Linda asks, how long does it typically take for a review to be completed by anyone, a doctor or a technologist?
That's depends on your physicians and your technologists and what sort of deadlines you provide to them. But the thing to keep in mind, if you know that a physician takes a really long time, you may want to definitely give them a deadline. But the average amount of time that it takes to complete really just depends on them and how quickly they can go through things. I can't really give you a time for that.
So next question is from Fikri. He asks, is the interpreting physician allowed to review his own cases?
Yes, the interpreting physician is allowed to review his own cases. Again, that goes along with the variability. And even though he is the only one that interpreted those cases, if it's from a month ago and he goes back and looks at it, he may find things that he doesn't necessarily agree with. It is another good way to assess the interpretive quality.
Janet asks, does the information regarding appropriate use have to be included in the final report, or can it be obtained from the patient history?
It can be obtained from the patient history. As I mentioned earlier, there are certain laws that are going into effect that may require it to be on the final report. I don't want to give too much information for that, but the American Society of Nuclear Cardiology is definitely a very good resource for this.
Rafiq asks, some of my earlier quality assessments, I had not used the QI tool. Is that acceptable?
It is still acceptable. The QI tool, use of the QI tool is not required. It is purely voluntary. If you are still performing separate assessments of each one of the 4 measures, that's completely fine. As long as you're discussing the 4 measures, as long as you are looking at different aspects of technical quality, interpretive quality, and final report completeness and timeliness, as well as AUC. You just have to keep in mind that all 4 of the measures need to be completed. So why we recommend the tool is also because it's going to put everything together. It's going to also save you time and make things probably make a little bit more sense. But again, it's up to you. It's purely voluntary.
All right.
Probably have time for one more question.
Last question from Dana. Was the case correlated with studies from other modalities? Should we mark no if there were no other studies available for comparison?
Yes, you can mark no. That question is not added into your overall score. It is there just for your review, but it's not seen as a negative answer because there is really we can't tell you whether there's a right or wrong answer, but if it was correlated, then it's good to make note of that.
Thank you very much, Maria and John. Thanks again, everyone. Please feel free to contact IAC with any questions that were not answered during the Q&A session. To receive continuing education credit for attending this webinar, please complete the survey. The survey will appear on your screen automatically at the conclusion of the live session and also be available from the IAC webinar portal for 3 business days. On the left side of the My Account page, you'll click on Webinars. Look for the title of this session, Navigating the IAC QI Tool, Collect, Measure, Improve. Beneath this title, you will click Review Event. On the left, select the Evaluation tab, then click Take Evaluation to complete the survey. Your certificate can then be accessed and printed from the very next screen and any time thereafter through the CE Transcripts section on the My Account page. If you have any questions about the survey, please contact us at webinars@intersocietal.org. Once again, we thank you for joining us today and appreciate your participation.